Now we invite Dr. Alia Yamin to talk on Haze, causes and management.
A very good morning to everybody. I'll be talking about corneal haze and its management. So despite the efficacy of surface ablation, as we've seen it is flapless, it can be bladeless, and it can be done for thinner corneas, there are still risks for complications, haze, pain, and delayed recovery. I'll be talking about the haze aspect. So what is corneal haze? Corneal haze is basically subepithelial corneal fibrosis, which is basically a manifestation of the pathological healing. So here you see a normal, how a normal histology of corneal layer look like. And here you can see the subepithelial corneal fibrosis in the stromal layer. So a traumatic procedure, that is epithelial removal, is done before any surface ablation. It can be done with a surgical tool or with a Moyles brush, or it can be alcohol assisted, or as in trans-PRK, it can be again done with laser beams. So what happens is there is a break in the epithelial barrier, which causes a epithelial stromal lesion. Basically, the basement membrane of the epithelium and the stroma is affected, which causes an inflammatory response, leading to the penetrance of profibrotic factors, migration, multiplication, and differentiation of keratocytes into mature myofibroblasts. So basically, haze decreases the overall effect and the motive of our refractive therapy. It can cause halos and glares, alteration of the contrast vision, and irregular astigmatism, causing an overall decrease in the best corrected visual acuity. So as compared with traditional PRK, the trans-PRK induces significantly less haze. Basically, trans-PRK limits the initial keratocyte apoptosis, which reduces subsequent repopulation of the activated stromal keratocytes and wound healing response. It also forms a smoother and a more uniform stromal bed contour, and also a shorter duration attenuates the tissue dehydration before ablation, which is again causing lesser haze. So here we see a typical picture of epithelial abrasion using trans-PRK in the first picture, where we can see a clear visible margin, in contrast to a Moyles brush, where we cannot even see the margin and is more irregular. So apart from the change in the technique of epithelium abrasion, we can reduce the haze by, so there is a direct relation. When there is more ablation depth, there is more incidence of corneal haze. So in our practice, it has surface ablation is contraindicated in hypermetropic patients, in myopia, spherical equivalent of more than 6 diopter, or even high cylinders over 3 diopters. So hyperopic and large myopic or astigmatic corrections carry higher risk of haze. Coming to the haze scoring, clinically, there is a Fantis et al. Scale, which signifies as grade 0 when there is no haze, 0.5 when there is trace haze, which is seen with careful oblique illumination, grade 1 when the haze is not interfering with the visibility of fine details of the iris, grade 2 when there is mild obstruction of the iris details, grade 3 when there is moderate obstruction of the iris and lens, and grade 4 when there is complete opacification of the stroma in area of scar, anterior chamber is totally obscured. Apart from clinically judging, we also have an objective method of seeing the haze, which can be seen with Pantacam densometer, where it is standardized form from 0 to 100 grayscale units, 0 being the minimum light scatter, that is maximum transparency, and 100 being the maximum light scatter, which signifies minimum transparency. So to start with the procedure, we can have preventive methods to not have haze post-operatively, which basically is the selection of our patients pre-operatively. Photoablation greater than 75 or 80 micrometers should be avoided. Hyperopic patients should be avoided. Any large cylinders or high myopia, as in -5 of spherical equivalent of myopia, and astigmatism of 3 diopter or more should be avoided. And where there is residual corneal tissue less than 400 micrometers should be avoided. Intraoperatively, we use adjuvant mitomycin C therapy. Basically, it is an alkylating agent that inhibits cell growth. It has anti-metabolite activity, which is useful in preventing haze induction by inhibiting the corneal collagen synthesis, and it is used in a dose-dependent fashion. But there are obviously cytotoxic effects of MMC, so an appropriate dilution of MMC, appropriate application time, and application should only be confined to the central cornea. There should not be contact with the surrounding structures like conjunctiva, sclera, or limbus stems, as it will lead to delayed reepithelialization and sterile melting. So according to different studies, as with the 15 years of MMC for surface ablation, which was published in iNet magazine, certain rule of thumb for MMCU was formulated. It said that it is not necessary in lower degrees of myopia. Only patients with more than 5 diopter of myopia or more than 1.5 diopter of astigmatism, it should be used, and not to any ablation deeper than 75 micrometer. Apart from that, in American Academy of Ophthalmology, it was a meta-analysis done over the last 15 years of using MMC. It said that lowering of the dose ranging from 0.02% to 0.02% were used in different cases, and the application time was varying from 30 seconds to 2 minutes. So a lot of different conclusions were formulated. The nomogram that we follow at our center is we use 0.02% MMC for 10 seconds for every 1 diopter correction over a spherical equivalent of 3 diopter or more, and which is followed by a copious irrigation. And according to our nomogram, the results have been great, and no corneal haze has been seen in any of the patients so far. Apart from that, MMC may prevent the normal regression that occurs with wound healing. This is another important factor. So it causes a resulting overcorrection of the refractive error. Hence, a nomogram adjustment has to be done to compensate for this. So the planned ablation should be decreased to prevent a hyperopic outcome. Apart from that, in the post-operative period, to manage the haze, prescribing vitamin C in the form of oral supplements or vitamin C rich food to your patients. More prolonged low-dose topical corticosteroid regime for lasting up to 3 months. And it can be further stratified based on the early or the late onset haze. And also instructing the patients to wear standard sunglasses protection against the ultraviolet B rays, because that is also another reason for haze post-operatively. So the haze can be transient, as in the physiological haze, or it can be late haze, which is termed as the pathological haze. So the physiological haze usually clears up in 4 to 6 weeks and might prolong to 3 months. But just in case, if it is prolonging more than 3 months, that is the pathological haze, wherein the surgical management comes in. So for the superficial corneal haze, a mechanical debridement or superficial PTK can be used. And for a deeper corneal haze, deep PTK or PRK can be used. In another study, the management of the haze according to the grade has been again for grade 0 to 2, a combination of topical steroids and NSAIDs, and grade 2 to 4 mechanical epithelial debridement with or without MMC or with laser scrape.